So, good day. The lecture is entitled Tissue Renewal and Repair. So, let's discuss some of the definitions that we're going to use in this lecture. So, repair or healing. So, in the past, repair means restorations of functions of a particular solid organs, while healing pertains more on the surface epithelium. But we will use the word repair, which is defined as the restoration of tissue architecture and function after an injury. Now, there are two processes of repair. The first one is regeneration, basically to restore normal cells. And for the purpose of this lecture, we will focus more on the liver. And the second process of repair is your scarring or connective tissue deposition. Now, there are terms also involved within this type of repair. We have what we call the fibrosis, which is the deposition of collagen occurring in your lungs, liver, and kidney as a consequence of chronic inflammation, and in the myocardium, which is mainly caused by your ischemic necrosis, as in myocardial infarction. And then we have the term called organization. A fibrosis developed in a tissue space occupied by an inflammatory exudate. So somehow the term organization is almost unique to lungs, especially after a pneumonia. So basically in organization, the alveoli in the lungs are filled up by granulation tissue. And organization can still be reversible if proper treatment or interventions will be done to the patient. So in this photo, you can see here a normal skin and subcutaneous tissue. So a mild superficial injury would always lead to regeneration. So only the epithelial linings was injured in this part, while if there's a severe injury like an avulsion, so really a portion of the epithelial lining as well as dermis and subcutis was removed because of injury, and so there's a scar formation. So we can see here these are all filled up by granulation tissue, and so you can see here the spindle-shaped cells, these are fibroblasts. So even after the scar formation, there is still some defects present. Now let's go to the principles involved in cell and tissue regeneration. Basically, there are three cells involved in the cell proliferations along with their signals and control mechanisms. So these are the remnants of the injured tissue, your vascular endothelial cells, and your fibroblasts. Now let's take a review of the cell cycle. So there are four phases in the cell cycle. You have the gap one, there's a growth phase, and then you have the S phase, which is a growth and DNA synthesis. The gap 2 or the G2, there's a growth and final preparation for division, and the M phase or the mitotic phase. So G1, S, and G2 are all interphase, and then the mitotic phase, the M stage or M cycle. Let's first discuss the three groups of tissue based on their intrinsic proliferative capacity. So we have the labile or continuously dividing tissue. These are your hematopoietic cells, such as your red blood cells, WBC, and other immune cells. This can also be your surface epithelial cells from the skin, oral cavity, GI tract, and GU tract. And then we have your stable cells. These are actually cells at the G0 stage of the cell cycle. So these cells are capable also of repair or proliferative capacity, but on a limited basis. Examples are your solid organs like your liver, kidney, and pancreas. And then we have your permanent tissues such as your neurons and cardiac muscles. But strictly speaking, your cardiac muscles can still capable of tissue regeneration, but in a very, very limited extent. So for practical purposes, your cardiac muscles are considered to be permanent tissues. So to recap, we have your labile or continuously dividing tissue, which are cells continuously being lost and replaced, like your hematopoietic cells of the bone marrow, your surface epithelia, like in squamous, cuboidal, columnar, or transitional, and then you have your stable tissue. These are cells at the quiescent phase with minimal or limited proliferative activity, like your parenchyma of solid tissue, your endothelial cells, your fibroblast, and smooth muscles. And then we have your permanent tissue. These are your terminally differentiated, non-proliferative in postnatal life. And examples are your neurons and to some extent your cardiac muscles and skeletal muscles. Now, the cell proliferation is driven by signals provided by your growth factors and from your extracellular matrix. So these are your growth factors. You have your epidermal growth factors, your TGF, hepatocyte growth factor, your vascular endothelial growth factors, the platelet-derived growth factors, the transforming growth factor, and keratinocyte growth factors. So the main origin of these growth factors are mainly your macrophages, the activated macrophages, your stromal cells or the mesenchymal cells, and your epithelial cells. Now, what are the mechanisms involved in tissue regeneration? So if we're going to discuss the tissue regeneration, the representative tissue here would be your liver because it is well studied compared to the regeneration involving your surface epithelium. So of course, the anecdotes about this is that we have the story about one of the titans, Prometheus, Prometheus who was punished by the Olympian Zeus because of disobedience when he gave fire to the human, and so he was tied in the cliff of a mountain, and then every night a vulture would visit him and would eat his liver, and then the liver would regenerate overnight, and then the next day the vulture would be there again to eat his liver. So this is just really the story about how the liver can regenerate easily. In fact, a liver can regenerate even if there are only 10% left in your original organs, such as what happened during acute, let's say, fulminant hepatitis. So let's now focus on the liver, but this is basically the representation of various organs that can develop regeneration. So the first mechanism is the proliferation of remaining hepatocytes, let's say following partial hepatectomy, for example, from a tumor. So the first step here is that priming. So your tumor necrosis factors found in your Kupffer cells will also allow the release of your interleukin-6 that would prime the remaining hepatocytes to go into transition from G0 to G1, and this will also be stimulated by other factors like your hepatocyte growth factors, your epithelial growth factors, your transforming growth factors, and other signaling proteins. And these cells will undergo cell proliferations to become your new hepatocytes. And of course, the process should be terminated by other factors. So there would be some kind of negative feedback in the process. The second mechanism is that the liver itself contains some progenitor cells, and these are called oval cells or oval cell precursor, found in your canals of Hering, which are also found in your sinusoids. So there are no need really for the conversion or the priming process, but simply the oval cells will transform or differentiate into liver cells or mature hepatocytes. Now, what are the steps in the repair by connective tissue deposition, or in scarring, which is the second type of tissue repair? Now, in the book, we have 4 steps, but I include here the 5th one, which is the remodeling of connective tissue. The first step is the inflammation, which are both your acute and chronic inflammation occurring from 6 to 48 hours. So this would be followed by cell proliferation around 10 days, and these are the cells involved, your epithelial cells, which can your source of your EGF or epithelial growth factor receptor as well. Then you have your endothelial cells and parasites, which are involved in your angiogenesis or formation of new blood vessels, which I would explain later. And you have your fibroblasts. These cells are responsible for the laying out of collagen and other extracellular matrix. And then the third step would be the formation of granulation tissue. And the fourth step is the deposition of connective tissue. And basically that involves the remodeling of connective tissue. So in the 4 processes, the macrophages involved is the alternatively activated M2 type macrophages. So these are they do not participate basically in the antigen presentation in phagocytosis, but rather in this process, the alternatively activated M2 type macrophages. So again, just to represent in the photo, so the first step would be your inflammation. It can be acute and chronic. That is basically to remove and clear the site of injury from any microorganism and necrotic debris, and that will somehow also improve the circulation, followed by cell proliferation, eventually formation of granulation tissue, then deposition of extracellular matrix, and remodeling of their extracellular matrix. The endpoint would be the formation of a scar. Now this is how we see granulation tissue in the microscope. So you can see here a lot of small capillaries, or the process of neovascularization, and there are also some fibroblasts in the stroma, and probably some remaining inflammatory cells like neutrophils, lymphocytes, and plasma cells. Now upon staining with your Masson trichrome stain, it would appear blue. So these are collagen fibers from the granulation tissue. So a better magnification here of the granulation tissue, you can see here fibroblasts, you have the thin-walled capillaries and inflammatory cells as well. Now this is the steps involved, or just to represent or to give you the timeline. So there would be an inflammation from around 2 to 6 days or even 48 hours. Cell proliferation would occur from around day 6 to day 10, and then from around day 10 the cell proliferation process is almost complete, and then it would proceed to maturation, which is actually the deposition of extracellular matrix and remodeling of your extracellular matrix. So again, the inflammation would occur the first 3 days, and then a granulation tissue, and then the wound contractions and the formation of scar. Now angiogenesis, when we say it is a process of new blood vessel development from an existing blood vessels. Now there are several steps involved. There is the vasodilatation, the separation of parasites, the migration of endothelial cells, the proliferation of endothelial cells, remodeling into capillary tube, recruitment of periendothelial cells, and suppression of endothelial proliferation and migration, and deposition of the basement membrane. So basically this is a process. So your quiescent vessels with specific angiogenic factors would become dilated, so basically on one side here, and then there would be a leading tip by a VEGF and notch signaling and the parasite detachment, and there's also a basement membrane degradation. So actually one side of the blood vessels are being pulled together, and there's somehow an elongation of the vascular stalk, leading basically to the formation of new blood vessels. So this new blood vessel is like a bridge between two existing blood vessels. Now, to explain further, we can see here, so one side of the blood vessels here, and then the blood vessels will vasodilate in response to nitrous oxide. And in one side, there will be a separation of pericyte, also in response to nitrous oxide. And then the tip cell formation, breakdown of the basement membrane, and this is stimulated by your VEGF-A or alpha, and the formation of the vessel sprout again. And then there will be a proliferation of your endothelial cells, vacuole formations, and these are all remodeled into capillary tubes. So the same happened in a nearby or adjacent blood vessels, and these would create a remodeled capillary tube, and so now you have a new blood vessels, a bridge between the two existing blood vessels. So these are the mechanisms of your angiogenesis and the signaling involved. So take note of the BEGF, the Notch signaling, and other factors or growth factors involved. Now, what are the steps in scar formation? This is now the deposition of your connective tissue. So two steps basically are involved. There's a migration and proliferation of your fibroblasts and deposition of your extracellular protein or extracellular matrix protein produced by these cells. So take note that the most important cytokine for the synthesis of deposition of connective tissue is your transforming growth factor beta. And then your fibroblast, some of your fibroblasts will acquire the features of smooth muscles because the scar will have to have some kind of a contractile property, so the fibroblast will transform into myofibroblast. So again, the first step is the migration and proliferation of your fibroblasts. So the source of your fibroblasts can be your epithelial cells at the site of injury, the endothelial cells. The bone marrow can also produce your fibroblasts, and your vascular smooth muscle pericyte. The fibroblasts to some extent will transform into myofibroblasts, and they will synthesize matrix protein like collagen, and eventually this would lead to fibrosis. Now, the remodeling of connective tissue is a balance between synthesis and degradation of extracellular matrix. So once the scar formation is completed, some of this ECM will be degraded, and there are enzymes involved. We call them as your metallic or matrix metalloproteinases, MMP. So example of these are your interstitial collagenases, your gelatinases, and your stromylysins, like in this field here. So your collagenases will cleave your excess fibrillar collagen. Your gelatinases will cleave or degrade amorphous collagen and fibronectin, and your stromylysin, the proteoglycans, laminin, fibronectin, and amorphous collagen. What are the factors influencing tissue repair? Of course, infection. So if there are infections, of course, the process really cannot proceed as smoothly as it should. And there's a diabetes, so the presence of excess glucose or high level of glucose in the blood basically can inhibit your immune cells from functioning properly. You have your nutritional status, for example, for vitamin C deficiency that can also inhibit the synthesis of your collagen. Your glucocorticoids, which are anti-inflammatory in nature, and they actually inhibit fibrosis. Mechanical factors, of course, so presence of or continuous movement at the site of injury can impede the healing process. Poor perfusions, of course, if the area lacks oxygen and blood supply. We have foreign bodies that can also prevent or slow down the healing process. Type and extent of injury and location of the injury. Now, let's discuss the healing of skin wound. There are two types. The healing by first intention. So this is an injury involving only the epithelial layers and the main mechanism here is epithelial regeneration. So this is also called primary union. So the best example here is the surgical incision during surgery. So the main injury basically only happened mostly at the epithelial layers, and so limited injury, this would be either the incision or the injury is limited. The healing by secondary intention, obviously, this is from the injury can be severe, irregular, and can be due to trauma or other mechanical manipulations of the wound. So here, healing by first intention, for example, as an incision, a surgical incision, would have very little damage to the surrounding tissue, and so the healing process can proceed as smooth as possible, and in weeks, restoring the tissue to almost its normal original strength. While healing by secondary intention, if, for example, in avulsion, or really a portion of the skin, for instance, was removed or taken out because of some trauma or injury, the healing process is really slowed down, and because of other damage to other structures here, like damage in your dermis, the surrounding blood vessels, and even muscles. So there's a delayed process, and the tendency is for you to develop scar formation. So what is the difference between your wound healing, first intention versus secondary intention? So just to recap, your first intention, the edges are lined up, or very minimal injury, while in second intention, the edges are not lined up. So you produce more granulation tissue, bigger granulation tissue, more epithelialization, and more fibrosis. So scarring here is more marked and probably bigger. Your wound strength, actually a carefully sutured wound, have an approximately 70% strength of the normal skin. But after about 3 months, the maximum strength in that particular site of injury is only up to 80%. It can never reach, or it can never be restored back to 100%. So any injury can only have 80% at the most. Now there are also some controversial part in the tissue regeneration we have called the fibrosis, or in parenchymal organs. So this is also an area of research. So they are trying to identify the specific processes and structures or signaling involved in the fibrosis in parenchymal organs, such as the presence of fibrosis in liver cirrhosis, the fibrosis in idiopathic pulmonary fibrosis, as well as other problems involving fibrosis in the kidney, heart, and even fibrosis due to tumor. What are your abnormalities in tissue repair? The first one would be your defects in chronic wounds. So basically here, the tissue repair is delayed or not completed because the overlying skin has an inherent problem with epithelial ischemia and ulceration. So for example, in venous leg ulcers due to varicose veins and congestive heart failure, once you develop injury in that part of the body, it tends not to heal immediately, or the healing process can really take some time, or it may not happen at all because of the ischemia and ulceration in the overlying skin. Same goes also with your arterial ulcer due to atherosclerosis, in diabetic ulcer, and in pressure sores. So this is an example of your venous ulcer, your arterial ulcer, your diabetic ulcer or diabetic foot, and of course your pressure sores, wherein here the skin is in constant pressure, so they are also in constant state of ischemia, and this is your granulation tissue. The second abnormalities or set of abnormalities is excessive scarring due to excessive formation of components of the repair tissue. So you can develop hypertrophic scar. So the scar is more marked, but it does not exceed the original size or site of the wound. And then you have your keloid, wherein it's very much similar to hypertrophic scar, but the scar here is hard, darker in colors, and can really extend beyond the original site of the injury or the wound. And then you have your exuberant granulation tissue or proud flesh. So here, the granulation tissue form is also outside the wound and basically beyond also the site of the original wound. And then you have a desmoid tumor or aggressive fibromatosis. So these are also a result of some kind of fibrosis, but these form a tumor-like lesions, and they can be found usually for injury within the deep compartments of the body. And they have some theory that this can be really a neoplastic in nature. And you have your contractures, so these are exaggerated fibrosis usually occurring in areas of digits, toes, and even joints. So this is an example of your hypertrophic scar. So the scar here is still marked, but it does not extend beyond the site of the wound. While here you have the keloid, so the scarring appears to be nodular, darker in colors, and they basically disfiguring and extend beyond the site of the wound. So this is your keloid here, showing here a thick bands of collagen fibers, usually in the dermis. So what are the differences within hypertrophic scars and keloids? So hypertrophic scar is a raised, linear, firm lesion compared to the keloid, which is also raised but hard. It develops within 3 months for hypertrophic scar, where keloid, it can even extend up to 1 year. The hypertrophic scar remains within the boundaries of the original wound site. So this is probably the most important difference between the two. While keloid scars spread outside the margin, invading your normal skin. Hypertrophic scar is common post-burn injury, where keloid scar for dermal injury. Type 3 collagen and type 1. Not typically associated with pigmented skin, associated with darkly pigmented skin. Not familial, can have a strong familial tendency, and they tend to be more common among Black population or African population. Black African, and then affect any age, common in young age, can regress spontaneously and do not regress spontaneously. So this is what we call exuberant granulation tissue. So not yet scarring, but at the stage of granulation tissue, so it tends to be protruding out of the skin. And this is your desmoid tumor from a posterior posteromedial or posterolateral thorax. And you have your contractures from excessive fibrosis in your fingers. That's the end of the lecture. Thank you.